Well, thank you very much. I really appreciate that introduction, Josh, and I hope I can live up to it. It's a pleasure working with this team that is doing the presentation today. I'm really glad to be a part of it, and hopefully I can share some information that's valuable too. Next slide, please. I think this is a time that there are many opportunities out there for employer health plans and for consultants. If we look at the headlines that have been running in the newspapers from these different, through this pandemic, we see a wide range from that are impacting employers, from shutdowns and layoffs to ensuring your employees are safe. But I particularly like the headlines that Sherm posted in the lower left-hand corner. And there was two articles. One said employer healthcare costs are expected to rise due to the coronavirus. The other said, no, there are options for lower prices. And I put this out there because I think it is a time that employers and consultants are in a position to really make some changes. Next slide. Most of you know the Montana story, but when I took over the health plan in late 2014, the actuarial projections showed that the plan reserves would be at -9 million in just 2 years if we did not do some drastic changes. So we did. What I'll be telling you today are the basic things we did, which follow exactly what our previous speakers have talked about. I followed that Health Rosetta model. And as a result, we ended up with 112 million in reserves in that span of time, to the point that we had more in reserves than the Montana General Fund. And the state was borrowing money from us for most of the summer of 2017. And then a special session was called, and in early 2018, a premium holiday was given to the employers so the state general fund could receive 25 million from the reserves. Next slide. So our goals were not to raise member contributions or out of pocket, not raise employer contributions or flatten or decrease costs. We had to flatten or decrease the costs, and we had to restore the reserves. So we did not want to push this off on the employees. We did not want to push it back on the legislature. We wanted to restore the reserves. And the only way to do that was to take money out of the healthcare system and at the same time improving the employee benefits, as our previous speakers have noted. So our strategy had 4 steps. Number 1 was primary care, which we've talked about. Secondly was hospital costs. Hospital costs are the largest portion of your health plan spend. For Montana, just the Montana health plan costs represented 43% of the total plan costs. Of that, 87% of that chunk was attributable to 11 acute care hospitals. The third phase was looking at PBM and RX benefits. We knew there'd be money to be saved there. And then I liked how Dave called it spring cleaning. We did look at our health plan, but we looked at the multitude of vendors we had too, and I strongly urge you to think about cleaning up your plan. So let's talk about the first one, primary care. It serves as the member's first point of entry into the health system. And I think you just heard all the benefits of primary care, and we knew that's what we needed. We needed access to good primary care. The state already had a vendor in place for on-site health clinics. We have 5 health clinics serving 73% of the members. And it was only 3% of the planned costs. We did put more money into primary care, but we also shrunk the total plan cost. So it ended up being 5%, which was a good place to put our money. We refocused the health centers on primary health care only. There was no copay or coinsurance for the different services, so access was very easy for members. We negotiated 18% admin fee reduction with a bonus program for the administration. And we actually contracted for more health coaches and mid-level providers. But there are many, many other options. that are available besides on-site health clinics. You've heard about DPC, you can do direct contracting, you've heard community-based solutions, but our first effort was to primary health care. Next slide. The biggest thing we did, and I like rolling out this little introduction here, as Josh mentioned, I work for NASHB, and we are looking at following the money through the healthcare system. And this is just a little preview of some work we're doing at NASHB. When it comes to hospital costs, it's important to realize that you, the employer, taxpayers, employees, consumers, and patients, you're the ones putting the money into the system. So I get very upset when I hear the large carriers call themselves payers. They're not the payer. You're the payer that's putting the money in the system that then goes to the hospital. And I took this position realizing that we were the payers. We were working with taxpayer money, and we are in control of where that money goes. And it's important that you flex that power. Next slide. So we took on an initiative to switch from the basic hospital pricing of discounted charge master. We wanted to base our reimbursements as a multiple of Medicare. So it was reference-based pricing, as it's usually called. But we wanted contracts with every single hospital so there'd be no balance billing to members. We ran our claims through a repricer. We found out what we were paying as a multiple of Medicare at the different hospitals. We targeted the 11 acute care hospitals that comprised 87% of our Montana hospital spend, with the goal of moving the high end down to the lower end, just narrowing that spread. We started this in April 2015, or excuse me, 2015. We immediately terminated our contract with a large BUCA plan. We did an RFP. We found a third-party administrator that would implement this for us, and this generated a lot of savings. So our strategy with the hospitals was definitely moving to Medicare reference-based pricing. But there are many, many other things that you can do as a plan. You can look at community-based solutions like Dave touched on. You can look at direct hospital contracting. We did reference-based pricing. You can look at narrow networks. In Montana, the governor's directive as a state health plan was not to go that direction because employees at all hospitals are taxpayers. You can look at shopping tools, price and quality. I did not find them as effective as the direct contracting and reference-based pricing. Hospital bill review, you can pull a lot of money back out of that system. We're starting to see what is called claims payment accuracy, and this is focused on the TPA and carrier. And we're seeing some very interesting results come out of that, of where the carrier may be keeping spread, just like you see in PBM contracts, where what the employer pays to the TPA or carrier is not necessarily the amount that ends up going to the particular provider. And we're starting to see more done in purchasing co-ops, bringing together several groups for steerage. But I think this is a big area to hit. Third, we hit PBM and pharmacy benefits. We analyzed our current contracts. We found spread, caps on rebates, a very ineffective appeals process, and high administrative fees. We contracted for a transparent pass-through pharmacy. We saved 23% of our plan spend that first year. We put in AGWIP. That is for retirees if you still carry them on your employee group plan. Moves them into a Part D plan, and it saved quite a bit of money. And we actually paid less in administrative fees. But we added on a Montana solution for medication therapy management. We brought together a collaboration of the Montana Independent Pharmacists, the University Pharmacy School, similar to what Dave talked about in Community Solutions. They do direct member outreach for pharmacy drug adherence, chronic condition care, and coordination of therapies. And finally, the fourth area that we moved into, next slide, please, was to clean up the plan products. I named just a few of them here, but it's not surprising to walk into a plan that's been around for a while and see that they stacked vendors to try to find different products that might help. The first thing to do is really look at all these products. When I went to the state of Montana plan, there were 4 wellness products, 3 vendors, and they were stepping on each other. We immediately trimmed it down to only the wellness program that was offered through the on-site health clinics and 1 staff member to coordinate that. We saved $5.5 million immediately. So I urge you to look at some of the products which your consultants can help you with that might help your plan, but really look at, you might need to clean some of these out. Are you paying more for admin, or are you duplicating the services? Next slide. So my last thought I'd like to leave you with is a great quote. Problems become opportunities when the right people come together. Okay, now I'm going to show my age because this is a Robert Redford quote. I was going to use the Winston Churchill quote that says, crisis always leads to opportunities, but sometimes I'm seeing that misused lately. A couple of examples I'd like to throw out. Through NASHB, we are working with state employee health plans and supporting their efforts to do a lot of the things we've talked about today. And through those conversations, even through this COVID-19 situation, we've had reported to us that one state employee health plan who really digs into their claims, digs into their data, has found acupuncturist claims that were reimbursed for acupuncture treatment for COVID-19 immunity. Another one is seeing chiropractor telehealth reimbursed. So to me, you know, those are some opportunists, but for you, the employers and the consultants, this is a time we're looking at how money can come out of that health center and implementing some of the things you'll hear about today. The time is perfect.